have to look at the volume of the entirety of the ventricle.
And so based on that, do you believe there's anything significant?
No, and I'll tell you further why, right? So if you had asymmetry in the ventricles, or let's say, for instance, he also described that there was an abnormality in the size of the ventricles, that they were actually more narrow or smaller. They're not. This is actually appropriate in size. And he suggested that because of that, there's probably due to increased intracranial pressure. But that doesn't happen in isolation. Increased intracranial pressure is going to cause fluid from the ventricles as well as fluid from the vascular space to spill out into the actual brain tissue, and that's going to cause abnormalities in the CSF pattern, as well as it's going to cause hyperintensities around vessels. You see none of that here in this actual scan whatsoever. Not to mention, increased intracranial pressure is going to push the brain parenchyma out. The brain is trapped in the skull. It has nowhere to go. So if you increase pressure inside that skull, the brain is going to be pushed outward and downward. And you see no evidence of that at all here. You don't see any evidence. You see the normal sulsation right here, or the normal folds of the brain. You have no evidence of that increased intracranial pressure. More importantly, like I said, there's no overt evidence of abnormality in ventricle size, and that matches what the radiologist saw on both the CAT scan and the MRI.
And what was the radiologist's opinion on the MRI?
The MRI was that there was no difference in the size of the ventricles, and that's important too. I know he had mentioned that normally a person wouldn't make comment of that on an acute CT. They very well would make comment of that, because if you see asymmetry on a CAT scan, what it suggests is that there's perhaps some underlying mass process that's pushing or changing the size of that ventricle that needs further evaluation. So a radiologist would certainly make note of that, and a doctor would certainly have to follow up with that.
Now, he also mentioned about the space, made some issue about the space between the skull and the brain. Can you
talked about,
describe
yeah,
that?
sure. So this is a little bit higher up, so I can't really see the temporal lobes here, but you can certainly look at, so here's the frontal lobes of the brain. The orbital frontal lobes are the part of the frontal lobes that curve underneath. And normally when you're comparing the width of the sulci of the orbital frontal lobes, they're going to be a little bit wider than the normal sulci that you're going to see on the lateral frontal lobes, as well as the sulci that you're going to see moving posteriorly to the temporal lobes. So what he's describing here is just the normal spaces between the individual gyri of the brain. And how do I know that? Because the cortical, so if there was atrophy, you would have loss of brain substance. You would have loss of gray matter, and you would have loss of white matter. The cortical size is of normal thickness. There's no loss of cortical size. More importantly, the distance here is all normal. So there's no loss of white matter underneath here. You don't have atrophy in the absence of loss of brain substance. Brain substance is absolutely normal. More importantly, this is all, the white matter from here travels down through the center of the brain into our spinal cord. If you lose substance, you get an increase in size in the ventricles. That's well known, and that's not seen here. So I see no evidence of atrophy at all on this brain. More importantly, when you look at the temporal lobe, he describes changes in the amygdala and the hippocampus. There is no atrophy whatsoever that I can see at all looking at this. More importantly, any atrophy, if there was, certainly I don't think wouldn't have any behavioral readout.
We could go to the next slide, please. What are we looking at here? Is this just more of him trying to say?
This is just, yeah, him using whatever program he has on his computer based on a scale that it has to measure the millimeter size or width of these ventricles. But like I said, look at the differences here between the posterior horns. It shows you that this is not on the same level, so it's slightly off. So you're getting more of an oblique or tangential cut through here, because again, like I said, you're dependent upon a person laying in the MRI tube. Nothing is going to be 100% level. So you really have to look at the entirety of the volume of the ventricle. So look at the volume of the ventricles at multiple levels, not just a single level, and take a measurement and then make an assessment of that. But like I said, if you did have alterations in this, then where is the alterations in the rest of the brain? We don't see that either.
And for the record, you were just referring to slide 3 of Dr. Rubino's PowerPoint. We're going to go to slide 4. What do we see here, doctor?
This is moving more anterior. This is moving more up towards the top here. Again, you're just looking at the white matter, but what we're looking at here, so this would be white matter tracts here, and again, he's talking about these spaces that you see here between the frontal lobe. Again, you could tell that they're at different levels, right? Look at the sulsations different, but more importantly, the white matter pattern is normal. The width of the white matter, I don't see any evidence of atrophy there. More importantly, if you have trauma, let's say we're saying this is due to brain trauma, All right, this is due to a deceleration, acceleration type injury or direct brain trauma where a person has an impact and then the brain moves both linearly, slamming into the front of the skull and the bottom of the skull, and then rotates about its center axis. And that causes a shear strain to the brain. Number one, it deforms the brain substance, and because the gray matter and the white matter are at different densities, they move at different speeds relative to each other, creating shear strain stress that affects not only the gray matter itself directly, much like if I punch myself in the arm, I'm going to get a bruise. And maybe if I don't get a big bruise, I'll get a little redness or definitely a change. Well, you would see that long term on the brain if you had a significant brain trauma. You would see hyperintensities, calcifications around small vessels. You may even see atrophy. More importantly, you would see an abnormality in the white matter pattern due to that trauma. Or you would see alterations at interface between gray matter and white matter, in particular along the long tracts that cross the hemispheres and go downward into the spinal cord and brainstem. And we don't see any of those changes here.
We can go to the next slide, which is slide number 5. What do you see here, doctor?
This is just, again, another example looking at the ventricles and trying to make an estimate that there are abnormalities in ventricular size. Also, arbitrarily choosing one point versus another point. Again, you can't make an assessment of ventricular symmetry by doing that.
We'll go on to the next slide, which is slide 6. What do you see in this slide, doctor?
Sure, now we're looking more towards the base of the brain. Here's the temporal lobes right here. You're looking into what would be, here's the midbrain right here. And it was probably more pons, actually. Pons, midbrain to pons, cerebellum. More importantly, when I look at trauma in a brain of someone that's had significant impact trauma, I'm going to see white matter pathology, very commonly in the cerebellar peduncular white matter that comes from the brain and brainstem into the cerebellum. I don't see any changes of that here, but more importantly, I don't see any atrophy of the parahippocampal region or occipital-temporal region, which houses the amygdala and the hippocampus. So no, I see no evidence of atrophy here at all.
All right, so if we could go on to slide number 7. Doctor, what do we see here? Is this just a further?
Yes, it's just another look at, yep, another level of that same region.
And again, everything appears normal on that slide?
Yeah.
All right, what about slide number 8?
This is actually a great just image looking again. This is now the orbital or the frontal portion of the brain here. And again, this is normal distance or normal spacing between these gyri that you see in this part of the brain. More importantly, as I said, you do not see the atrophy that I normally expect to see when it comes to trauma. The asymmetries that you see here in DTI pattern are quite normal in individuals because there's a functional, there's a functional hemispheric differences in white matter pathways, right? So there are laterality in functions within our brain because of our experiences, things we learn to do throughout our life. There's going to be differences in density of myelination and white matter in our brain, which will present as asymmetry. This pattern here is not something that I would be consistent with traumatic brain injury.
Moving on to the last slide, which is slide 9. Doctor, is this just another?
Looking a little further backwards, yep.
All right, and again, no abnormalities, nothing here
Yep.
that suggests any kind of brain injury.
Agreed.
Okay, thank you. You can step back up. So, Doctor, based on your review of these scans,
Yep.
would you have ordered anything further if the
Well,
defendant was your patient?
As a radiologist, or just as a physician for that matter, I would have looked at these and said a normal brain. If I was writing up a brain pathology report based upon this, I would call this a structurally normal adult brain, and I wouldn't be concerned about anything significant to chase after.
Now, another thing Dr. Rubino testified was about lateral asymmetry on the 2023 CT scan that was part of the medical records. Did you have the chance to review that?
Well, yeah, I did see those CAT scans. I know what he's referring to, and he's referring to basically the same asymmetry that we pointed to on the screen there. That is an asymmetry in the lateral ventricles, which were not noticed by the radiologist, and certainly I didn't notice any changes either.
So again, same assessment from 2023 as you've made now. There's no evidence of asymmetry.
Yes, I mean, our brain is not 100% symmetrical. And when you look at one side or the other, you're going to see differences in just the general morphology that you can pick out with your eye. But again, it's really the total volume. that matters. And in this case, that wasn't done. It's inappropriate to do one single measurement like that and then generalize to the asymmetry of a ventricle.
Now, the other thing he talked about was the difference in size of ventricles. Could you just explain whether that's significant or not?
So I know that there is certainly a wealth of literature out there looking at ventricular asymmetry and its involvement in psychiatric illness. The problem is that, still to this day, whether you have schizophrenia, bipolar disorder, or other well-known psychiatric illnesses, there isn't a neuroanatomical substrate that allows one to diagnose an underlying psychiatric condition. And so we can try to generalize by saying, well, this brain region is involved, we know that this brain region is involved in these types of behaviors, so therefore if we see a change here, we would expect to have this kind of behavioral abnormality. But that doesn't necessarily always hold true. There's certainly a lot of compensatory changes from one side of the brain to the other. And again, like I said, there's different functional reserves from one person to the next.
And again, based on the CT scans and SMRI, you saw no evidence of any sort of...
I did not see any evidence, and more importantly in this, I didn't see any limbic system atrophy.
Did you see any damage to the amygdala or the hippocampus?
I did not.
Now, the other thing that Dr. Rubino testified...
Just to add one thing, not only just the hippocampus and the amygdala, but the nerve fiber tracts that are important and integrate with that, the fimbria, the fornix, as well as the surrounding white matter.
And those were all normal.
Yep.
Now, we talked about the MoCA test, and I believe it's a one-page assessment. How would you describe the MoCA test?
Well, clearly my patients wouldn't respond well to that because they have no pulse. But what I would say, that's certainly something that someone uses as a upfront, quick assessment. It's certainly not I wouldn't base my diagnostic or my diagnoses, on that. It would clue me into what I should do further. In other words, if I'm doing an initial assessment of a patient and I see, hey, there may be a problem here with short-term memory or concentration, then I would do additional neuropsychological testing to really hone in on those abnormalities. A snapshot is a bad thing to make any opinions on, especially in this case because of the setting. We already discussed, and he even alluded to that when he performed the test, that there were guards overlooking Mr. Wilson, that he appeared nervous or anxious. That would certainly, cause an upregulation in your sympathetic nervous system or the activity of our sympathetic nervous system, which antagonizes normal short-term memory. And we can think all of us, if we were taking a test and we had someone looking over our shoulder, we would be much more anxious, and our ability to think through that test would be more difficult. And even you could talk to law enforcement officers who would tell you that, in situations of stress, when your heart rate goes up and it reaches a certain level, your ability to concentrate and think is decreased. So the same thing in this scenario. It's hard to really draw conclusions about one person's short-term memory from a single assessment. Furthermore, same thing with the cranial nerve assessments if a person is shackled or in a setting where they're not able to truly really give a true clinical examination. And lastly, I'll just say, again, reflexes and things of that nature. Sure, a person, Dr. Rubino has been doing this for 20 years, but understand that there is a subjective portion of that too, right? One person's 3+ out of 5 may be another person's 4+ out of 5. So there are inter-individual differences, even in the clinician who's doing who's performing the test.